My name is McKenna Janier, and today I will be discussing astrocytomas. As you can see in the picture, National Brain Tumor Awareness Month is in May and is characterized by a gray ribbon, so don't forget and try to raise awareness. In this next slide, we'll be discussing the history and evolution of astrocytomas. The astrocytoma was the first glioma tumor to be identified. Virchow first described it as glioma durum in 1840. In 1874, T. Simone identified an astrocytoma as a spider cell glioma. In 1895, M. von Lenhausen referred to an astrocytoma as astroma. So other nomenclatures include amoeboid giant cell glioma by O. Lotmar in 1918, fibrillary protoplasmic astrocytoma and astroblastoma in 1926 by Bailey and Cushing, afibrillary and gigantocellular astrocytoma in 1932 by Rousey and Oberling, piloid gemistocytic and diffuse astrocytoma in 1932 by Penfield. So the cerebellar astrocytoma was first described in 1931 by Henry Cushing. A histological description of the astrocytoma was first given by Bergstrand in 1932, and the reference for this is the reference number 1, which you can find on the last slide. Now discussing the evolution. So over time, research has been conducted about the development of astrocytomas. A normal astrocyte can develop into an astrocytic tumor through a series of genetic alterations which may progress into higher grades and potentially turn malignant. Many potential genetic mutations may be involved depending on the tumor type and grade. Some mutation examples can include the IDH1 and IDH2 and TP53 genes. For this slide, I wanted to include an MRI of an astrocytoma, which you can see in the top left corner. So on the right side of the MRI, you can see that the tumor is in the left temporal and occipital lobes, and it is quite large. On the left slide, you can see that there is no tumor, but there is an empty surgical cavity. Well, it's a resection cavity, but you can see that it's empty. The tumor is no longer there because that is the post-surgery MRI. All right, now this slide, we will be discussing the biological, social, and psychological impacts of this tumor. So if you have an astrocytoma, the biological impacts it can have is headaches, nausea, vomiting, visual field defects, gait disorder, seizures, and or aphasia. You can also experience personality changes, which could have a social influence, making it harder to engage or talking with others, depending on the change that you experience. A psychological effect is emotional instability. While personality changes can impact your social life, they can also affect you from biological and psychological standpoints. So these personality changes, while I did put them under the social impacts, they really could be biological, psychological, and social impacts. On this slide, we will discuss the prevention and treatment options for this type of tumor. So when discussing prevention, there are actually no preventative recommendations as the exact cause of astrocytomas is unknown. So due to there not being any preventative recommendations, I wanted to include some possible risk factors. So the exact risk factors of developing this tumor have not been identified, but some studies indicate there may be environmental and genetic disorders contributing to the development of this tumor. Research suggests that exposure to certain chemicals may increase the risk of astrocytoma in developing babies during pregnancy and infancy. Certain genetic disorders, such as neurofibromatosis, can cause non-cancerous tumors to form. So those could be a risk factor. So treatment options, these can vary depending on the astrocytoma type and grade level, but may include chemotherapy, radiation, and surgery. So radiation irritates the disease parts, and chemotherapy uses medication to help with treatment. Both of these work to try and help shrink the tumor. As for surgery, this includes removing the tumor, and many surgeons try to do a gross total resection if possible. So if it is a low-grade tumor, surgery may actually be the only treatment option required, but all three therapeutic approaches may be required if the tumor is higher grade. So you can see here for the preventative measures and the treatment options, I used reference 4, which again you can find on the last slide, which I will present to you at the end. Oh, I guess this is the end. Okay, so here are my references. You can see 1, 2, 3, and 4, and again you can go back through to see which slides are for which references. So I thank you all for watching, and I hope you enjoyed.